This is LiveWell Talk on atrial fibrillation, or Afib. I'm Dr. Dustin Arnold, Chief Medical Officer at United Point Health, St. Luke's Hospital. According to the American Heart Association, Afib affects an estimated 5 million Americans today, and 12 million are projected by the year 2030. Returning the podcast today to discuss atrial fibrillation is Dr. Talha Farid, cardiologist with St. Luke's Heart Care Clinic. Dr. Farid, welcome back.
Thank you very much. Thanks for having me.
Most of the public probably doesn't know what atrial fibrillation is until you start having the Xarelto commercials, and then I have non-valvular AFib, and so then I think people started it coming to their lexicon. But could you just tell us what atrial fibrillation is and why it's a concern?
So, atrial fibrillation is the most common treated arrhythmia. It's the most common sustained arrhythmia that we see in the practice. It's essentially an abnormal heart rhythm coming from the atrium, the upper chambers of the heart, where instead of one spot beating, there are multiple spots that are firing the same time. So there, instead of one spot, you have a few hundred that are firing the same time. So instead of beating and providing the atrial kick, which the atria are supposed to do, they're instead shivering. And so there are a couple of concerns with AFib. One is it increases the risk of stroke. So that's why Xarelto or Eliquis or other blood thinners come in the picture, that you need blood thinners to treat your AFib. But that decreases the risk of AFib, decreases the risk of stroke in AFib. It doesn't do anything for the AFib itself. So then comes the question, how to treat AFib, what to do? And that's where when we talk about procedures like cardioversion, ablation, antiarrhythmics, or the medications.
Now, historically, I felt like we spent a lot of time trying to get people back into sinus rhythm.
Yeah.
And then the pendulum kind of swung towards, just rate control and anticoagulate. Yeah. Where are we at now?
So, that's you're absolutely right. When I actually started my training, we had the trial, one trial, which essentially showed that there was not much difference between the outcomes. So we went to a point where we're not cardioverting or trying to maintain sinus rhythm in anybody who, quote unquote, didn't have symptoms. But then there was last 5 years or so, there have been extensive studies and such robust studies that show that people who maintain sinus rhythm tend to do better. They feel better, symptomatically they do better. And secondly, people who stay in AFib, even people who don't have symptoms, they develop MR, they develop TR, they develop regurgitation, valves start leaking. So ultimately, they develop all these outcomes from AFib, which could have been prevented by maintaining sinus rhythm years ago. So now, based on the literature and based on the new guidelines of AFib, which are published actually December of last year, we are very aggressive about
kind of going back to try to get people in the sinus rhythm.
Absolutely.
That was. I always felt it was worth a try to get them into sinus, and then, or sometimes look at the left atrial size and go, that's not going to work. We'll go back. Let's just treat. But what are the risk factors? I mean, how does someone? Because it can be silent. And a lot of people don't have it until it's discovered, by a physician. What are the risk factors?
So the risk factors are, if you're diabetic, you have high blood pressure, people who are sedentary tend to get more AFib. As we all get older, we just tend to get more AFib. If structural heart disease, if you have coronary artery disease, you have stents placed, you have valvular heart disease, then the risk of AFib goes really high. And there are there's some degree of familial component to it.
Oh, really?
That, people there are some people that you will see that don't have any of the risk factors, but they have AFib in their family too. Huh. Physical activity is actually a big factor. It's a U-shaped curve. So people who are very sedentary, they get a lot more AFib. You're physically active, you tend to get more AFib. But you can actually overdo, so high intensity exercises, athletes who do a lot of physical activity actually get more AFib.
Yeah. There was, I think it was the Milwaukee Marathon. They did study the post-marathon cardiomyopathy that marathon runners get. It was interesting. So we talked about the treatments. How would you treat the person that just presents with AFib, perhaps asymptomatic, but they have other risk factors? How do you go about initiating that treatment?
So, first of all, again, there are two components to it. First of all, you put them on blood thinners to minimize their risk of stroke. So that's especially based on their risk factors or CHA2DS2-VASc score that essentially looks at the risk factors of stroke in the setting of AFib. And the second part is treating AFib, and that's where shared decision making comes into play. We talk to these patients about what are the options. We, all of us in our practice, are very aggressive about trying to maintain normal rhythm in these patients. So the options are cardioversion, the options are medications, antiarrhythmics, and ablation. So then we talk to them about options, about the risks and benefits, and then it's a decision where you have to, patient has to be a partner in the decision making. There are some people who prefer medications and leave intervention for if medications don't work, which is absolutely fine as long as medications keep them in normal rhythm. But there are others, especially younger people, they're not good about taking medications. They prefer ablations. So in younger population, we actually proceed with ablation earlier, actually.
So when you do an ablation, is that, so you're zapping the heart from the inside, is that cold or laser or heat? What mechanism do you use?
So there are a couple of ways to do it. In the past, we had only thermal modalities, cold or heat. So now in last year or so, we have this, you might have heard the term called PFA. Essentially what means that we apply a lot of very high intensity electrical current. So it does not create heat. So it's non-thermal. And what essentially does, it results, it's a process called electroporation. So essentially it results in cell death without changing the temperature. So it has some benefits. The benefits are because you have less adverse effects. All of us have seen or heard about patients with AV fistulas from AFib ablation. These are very rare, but they can be they are complications, very high mortality. So in case of PFA, you don't have to worry about that since you're not changing the temperature. So it does decrease the risk of the serious adverse effects, makes the procedure more efficient. But not every modality is applicable for every patient. There are some patients who would benefit from one more than the other. But now we have more options.
When you go into ablate, and you had mentioned earlier, there's 100 different areas in the atrium that are misfiring. What do you ablate?
So this is based on a study actually that was published in 80s or 90s actually by Dr. Hazagara in New England Journal, which essentially showed that in paroxysmal AFib, there are foci of the AFib which are actually coming from the sleeves of pulmonary veins into the atrium. So all these pulmonary veins, when the heart tissue there's a sleeve of muscle that goes in the initial part of the pulmonary vein, and that actually is the main foci in about paroxysmal AFib we're talking about. So essentially what we do, we create a lot of, we call, depending on what modality you're using, we call it pulmonary vein isolation. We electrically isolate these veins from rest of the atrium. So if there are foci there, they won't be able to come to the atrium. So that's the main purpose of this ablation in paroxysmal AFib. When we talk about more advanced cases of AFib, like persistent AFib or long-standing persistent AFib, this is by itself is not enough in most of the cases, because now we're talking about quote-unquote substrate, the rest of the atrium. There's a lot of changes happening. There's fibrosis, there's dilatation of the atrium. So pulmonary vein isolation, those cases are not enough. So they need something more.
How do you know that when you start seeing them, other than risk factors and extending symptoms?
So first is depending on...
well, let me ask this question. Let me rephrase that. Do you know prior to the procedure whether it's going to be a pulmonary vein ablation?
Yes and no. Pulmonary vein ablation is the cornerstone for every patient. So every patient needs that.
Oh, okay. All right. Okay.
The question is, what else do they need? So it depends on a couple of factors. It depends on, first of all, if they're paroxysmal AFib, and you go in at the time of ablation, and we call, quote unquote, map the atrium, and the rest of the atrium is healthy, then you're probably not going to need anything else. But if you go in and you find a lot of disease and scarring and fractionation, and there are unhealthy areas, then you have to go take care of them. And the third part is you actually try to induce and see what other arrhythmias do they have, like the flutters, or so you take care of all that too.
Electrophysiology, you guys have all the toys right now. Used to be gastroenterology. Now it's cardiology. So is there anything new on the horizon for AFib that you could share with the listeners?
I mean, the most exciting technology that we had earlier was actually the PFA, because all this time that we were treating till last year, we were limited to thermal modality.
Right.
So
yeah.
the idea of able to take care of these patients with the procedure, which has minimal side effects or significantly less side effects, was quite exciting. There are a lot of things that are in the, we were talking before this, and I was just in a conference. There are a lot of things that are coming. There are a lot of work is going on right now. There are new technologies are in work right now, looking at what other options do we have. There are, another thing I would say is the surveillance of these patients is very important. And now we have options like all the smartwatches, which, we used to put Holters and all these monitors in all these patients. And now I literally ask them to invest in a good smartwatch that can monitor their rhythm. It can be extremely useful and can provide a very useful data.
Absolutely.
I'm very sure that 5 years from now, we would be in a different and a better place in terms of management of these patients.
I think when I think about artificial intelligence and medicine, I think you're going to see a lot of new discoveries and new devices and procedures just roll out faster, because they're able to do some of that research with power of AI and come to a conclusion instantaneously.
Absolutely, and that's taking part actually both in diagnostic and in therapeutic world actually, because we are able to diagnose these algorithms. We talk about smartwatches. If you incorporate diagnostic algorithms in all these devices, then it becomes very easy to tag these patients, and it's going to have therapeutic applications. We are having more and more. We are seeing more and more incorporation of AI in imaging. And imaging is very central part of what we do as EPs too. So its future is going to be very different.
Yeah. If the robots don't rise up and kill all of us, then then the AI is going to work out. If there's a little. Dr. Farid, thank you again for joining me. Once again, this is Dr. Talha Farid, cardiologist with St. Luke's Heart Care Clinic. To learn more about heart care services at St. Luke's Hospital, visit unionpoint.org/CR-Heart. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.